So now we're back again. I was talking before about this kind of different kind of communication that I see at the moment. There could, of course, be much more where we're heading. And this exists to some extent in everywhere, but I think there will be a big difference when it comes into the future. When is the future? The future is quite close, I would say. I will come back to that later with some examples. But still. And I think here we will see a need for a lot more communication. Why not here in the upper part? Because this is almost already built. We don't need any more power lines. Maybe one or two, but that's quite little compared to what's actually needed. What will come is later down here where we subtransmission, where we start connecting wind farms. We start connecting distributed generation. So that means there will be quite big changes here when it comes to control and supervision. So it will need to be extended, but also be used in a different way. Measurement, of course, will also increase in that case. The local grid will also develop in the same way, because smaller distributed generations will end up here. Small solar power installations, kind of businesses that are participating in different kind of control schemes, those kind of things. So more need here to operate, and that might create unusual situation in like power flows. Like for one occasion, the power flow goes in one direction, and some time later it goes in another direction. And that needs to be understood and to handle, because the power system is like something a little bit of a living organism, because it's so big and so complex, so you can't really understand everything. So you have to more go with the flow and understand how it evolves and moves. But the big thing, we say, will come up here on this 400 volt level, because here are the majority of loads. We will also see a lot of new production here. Me, for example, installed solar panels on my roof last fall, and that will have an impact on our 400 volts grid. There will be more. Hopefully in the future I will be able to trade my electricity. Today I can just sell it to anyone, but I mean to a broker. But in the future, here in Sweden, as they are discussing in Germany, you can sell it to someone else. So they can use my excessive solar power. But then also participating in trying to help control the grid, which will be a big thing, especially when it comes to the non-controllable production. We need to handle that in some way, because we need the balance. We need to balance the system all the time. So, and of course, if we end up storage using it, that will also require some kind of communication. So let's try to have an example that is close to you now. And this is the monitoring thing. You might have seen it. There are many of them. Here's one example. It's called a LIC. It's a system where you use the photodiode on your meter, because it blinks 1 to every 1,000 blinks per kilowatt hours, or 10,000 depending on different kind of meters. Then you read that will be transmitted to a hub, and the hub will then either transmit to a local screen or the cloud, as it uses, and you can easily see you can see how it looks like on the screen or the phone. But this is purely monitoring, and this kind of already exists. There is things going on. You can buy them quite cheap. The most simple solution, you can buy it at IKEA for 500 Swedish krona. So they are quite cheap, quite easy to install, and those kind of things. The next step is that is for monitoring and control. So we are looking into home automation systems. A lot of different manufacturers and different kind of solutions. I don't know if you use any of them at home. Here you also have the possibility to control. They are, of course, a little bit more expensive, because you need to communicate to each individual load, more or less. But that also means you can turn them on, you can turn them off. You can use them as an alarm. If someone goes in, you start blinking the lights in your apartment. If someone shouldn't be there and something goes wrong. So there are a lot of things you can control. You can put in measurement systems to control the temperature and all those kind of things. So this is what we have now. Because it exists, it's not that well distributed yet. But I think what we're looking for the next step is when you start interconnecting with your neighbors in small scale areas. To be able to meet and try to, instead of just not saving your own electricity, you start going together with others and make it happen. So that means it will be monitoring control of you and your neighbors, the block, or even the whole city. But the issue is that will be more complicated and more things to bring in. I mean, who should build, who should operate, how should it work? Of course, a common communication system. And here we look into in integrity issue, of course. And then the more social issue. What do you want in return? Except saving the world. You might have more egocentric targets of your life. But still. So here I think something will come when it comes to communication. And this system needs to be built in some way and operated cleverly. And here is an example what happens if you start sub-optimizing. By sub-optimizing I mean if one individual customer optimizes his work. The example is charging of electric cars. Some background. Here we have a slow power charging. We use 2 to 4 kilowatts. We need 8 kilowatt hours per day. That's in general how much we're using. We need 2 to 4 hours charging per day. And then we have the profiles of the cars where they are. Here is the commercial part, and here is the residential. So we know people are at home at night and away during daytime. And the opposite, of course, when you're in the way. So they should be some kind of mirror of each other. So what happens when you charge? If you don't control anything, you just see that you start charging when you have been out driving at home, you start charging in the afternoon, and all those maximums comes at the same time, where we today always have a maximum. And the issue with that is that means we need more capacity in the grid. We might have to expand the grid just to supply this 1 hour, even though there is a lot of capacity here and here, even though we know not a lot of people are driving between 3 and 4 in the morning. So by adding a personal control system, for example here, and the idea of course here is to minimize the cost of the drivers. So the personal, the egocentrical view on it. And that is when is the cheapest one. So when you're at home, you charge during night. And here the problems are even worse, because now everyone really comes at the same time, because they are responding at the same input signal, which is the electricity price. So that means we've got factor of 3, the maximum capacity, even though it's only used for 1 hour. But again, you're not doing something you're not allowed to do, because you're only optimizing your own way of living. And that's okay if 1 or 2 are doing it, but if everyone is doing it, we might have a problem. So, how this could be solved if we try to do something, for example, minimize the grid losses. And that is the way of using the grid as efficient as possible. So we're trying to have a common, let's say, work together to solve this issue. And then we will up with a very, very flat surface instead. And we can actually keep the previous peak. So we don't have to upgrade anything. No need for any new lines, no need for any new transformers. It doesn't require any space, doesn't cost any money. So just trying to work together might solve it. So let's try to summarize a little here. As I said before, a new generation of the grid is needed, and it will happen, irrespective of how you make your communication system. Because we have other things pushing this. And it will require communication. But that means also that new opportunities will arise. The most simple way, as I said before here, is on a low voltage level, on the 400 level. Because here we have the most thing to handle. But it will also come a little bit higher up in the system with problems like security and those kind of things. And we will also need different kind of communication systems. Some needs to be fast, someone needs high security, some needs to be understandable by all. This might be the most tricky part, because people might not think that electrical engineering or energy consumption is the most sexy thing you can do, or would like to spend all your time on looking on that meter, even though I prefer to do that, but that's another issue. And also we then end up in a system where it has to be reliable and cheap in this system, because the margin isn't that high when it comes to grid and operate grids. There could be a lot of savings done, but it will require a lot of actions on a different thing. So we need something in large scale, cheap, and reliable. And that's my last slide. Do we have any questions?
No questions, all right, then.
No?
Thank you for your meeting.
Yep. Oh, sorry.
5 more minutes.
Yes. You get them for free.
Thank
you.
you.
Thank
Very
you.
nice. Is anyone still using this? Fantastic.
All right, I have the microphone here for you.
Just let's see, where do we have, here is something that doesn't work. There should be an HDMI somewhere.
Huh.
I need to find
here.
There is something, yeah, thanks.
Oh, it's ridiculous.
Yes, there was something. Okay then.
Somewhere here.
Somewhere there maybe.
Uh-huh. Right.
It's in my pocket.
Okay, so this is our third and last guest speaker for today, Bengt-Arne Högqvist, and he will talk on e-health.
Yeah, thank you.
Thank you.
Okay, e-health, and since this is a course in communication, I will try to make a little review on communication aspects, but probably you will understand how important it is to have good communications when you're dealing with something like e-health. As you can see here, I'm involved in a number of different things here at and around Chalmers, and in fact I haven't been at Chalmers that long. My last period started in 2012. Before that I was in the industry, and before that I was a researcher here, and I did some entrepreneurship and innovated some ideas within e-health. So now I'm back again, trying to convince you how important it is to work with e-health. And just to give you a background quickly why I entered into this area. I started long ago as a PhD student in biomedical engineering. Started off working with neonates and trying to understand their way of breathing, etc. Then we started to work to see if we could join industry with the research we were doing here, and we started something called the Foundation for Biomedical Engineering. And we had a project on electrocardiograms trying to understand ischemia in the heart muscle, and that ended up finally in a company called Autobus, and a product for intensive care units, coronary intensive care units called Coronet, which is still around. I also started to work with communication, see if we could bring out healthcare from the hospitals into the patient's home. And one of the first examples we did was with neonates that had some kind of breathing problems when they were born, and then when they were in their process of getting better, we could bring them home instead of having them at the hospital, because it's a much better position to have them at home than having them in the hospital, because at home you are not that vulnerable for infections, for instance, and you are part of the family in another way than you are at the hospital. So if it's possible, it's a very nice thing to bring the babies home as early as possible. We did a lot of projects, and this is another one where we used telecommunication and satellites to support people that got sick on the Stena ferry to Germany. And we could send video, we could send various types of vital signs. We also started looking at how we can have monitoring of people suffering from congestive heart failure. That is when the heart doesn't have a chance to pump enough of blood in their own home. This was in fact a master's thesis by a design student, which did some prototypes, etc., including smart textiles. And this was some 15 years ago or something like that. Right now I'm involved in a number of different projects. This is a very big project running in UK, in Bristol, where we have some 60 to 100 researchers involved in a project trying to monitor people in their own homes without their knowing it, so to speak. We have cameras, we are looking into the electricity feeding and things to see whether they change their behavior. We can also monitor various parameters on their body. This is another project in the same area going here in Sweden. And in both these I'm in the advisory board. I'm involved in a company called Medfield, where we are developing methods to use microwaves to detect stroke and intracranial bleedings, for instance after trauma in a traffic accident, or if you have fallen down from the roof or something like that. But most important for what I will present to you now is this, the MobiMed system, which was an idea I had in my head some 30 years ago, which ended up in a company and also a product that we distributed around the world. And it deals with what is called pre-hospital care, that is care in ambulances, and how you can use modern communication to support the care that is being given in the ambulance and also to take care of the patient when it arrives at the hospital. So this is the outline. In fact, this is an old presentation I've used now and then and updated, of course, today, but it's based for more than 30 minutes. So we will probably end up somewhere here, just looking into what is e-health and have a little more detail on pre-hospital care. And if there are time, depending, maybe we go into these areas as well. But I guess we have to stop somewhere here because 3 o'clock we will finish. So the first question is, of course, what is e-health? Have you heard about the term e-health? I think most of you have done. In Swedish it's e-health. So it's very popular now and been around for a while, and I would say that it has been used so many times that we don't really know what it stands for anymore. I mean, you can always bring in anything you like in this area. But the simple definition is that this is about using ICT to improve care and promote health. And there are a number of ways we can do that. For instance, we can have more efficient ways of handling electronic patient records, or store images like in what is called PACS systems, and communicate between different hospitals, for instance their electronic patient records. We can have it as support in decision making. We often talk about something called computerized clinical decision support, where you use the information to make decisions on treatment, what care to bring forward, and things like that. There's also something that we call bring care closer to the patient. That is, we can, for instance, monitor people in their own homes, or we can follow up on diabetic patients or other patients using smartphones today and ways of communicating important information on these patients, and have that as a tool to decide on what treatment or if we shall make any differentiations in the drugs we are delivering or whatever it could be. Another very important thing, which I will talk a lot about today, is to improve care processes. That is, we will talk, for instance, about pre-hospital care. That is, what can we do to improve the process from an incident has occurred until we have those people involved or the patient involved at the right hospital and getting the right treatment. There is a lot of need of communication because there's a lot of many different actors involved in that process. And we have other tools for health promotions. You have probably seen that there's a lot of things around going on the smartphones. There are numerous apps to download. And some of these are merely for well-being or training and things like that, but there is a gray zone when it suddenly becomes healthcare. And that puts certain constraints on what you need to do with apps. When they are passing the border and becoming medical devices, it becomes much more difficult to test them and validate that they are doing what they say they are doing. But this is a very, very big area right now. And sometimes people talk about something called M-health, mobile health, when it comes to this. But again, that is a definition that is not very well defined. And this is a pretty old slide right now, but it gives you just a feeling on how difficult it is to say what e-health is. This is from the European Union and their programs, and they say, what is e-health? And they have a lot of things here, what it covers, etc., and some examples. And I really like the last one here. And many other ICT-based tools assisting disease prevention, diagnosis, treatment, health monitoring, and lifestyle management. So this could be almost anything involving any thing regarding ICT. This is another way to illustrate it. And here are a number of other interesting terms that you can maybe have heard of. Ambient assisted living. That is very much about how we are building up the intelligent home. That can support us when we heard about electricity before, but it could be anything about your heating and whatever, but also ways to support your well-being and monitoring your health. If you, for instance, have a long-lasting disease. And there are other things there. M-health, as I mentioned, telehealth and telemonitoring, which is usually defined within the area of telemedicine. And this was really the term when I started 30 years ago. Telemedicine was the hot stuff. And that was, in a way, making decisions on care when you are not geographically at the same place. You can, for instance, send an ECG and make the decisions on what to do on another place. But it becomes e-health when you put all these into a system solution. This is another thing that is going around very much, and you probably heard now. It's a digitization or digitalization of healthcare or anything within the society. And what that is really about is that is like bringing e-health into a concept, into our standard routines, how we provide healthcare or banking or whatever. For me, digitization started in the 1960s. When we started to digitalize and not using analog systems completely anymore. But this is the term they have invented right now for saying that this is a process that is going on in society and which everyone thinks will have a big impact on what will happen in the future. And there are a lot of different research being carried out, a lot of reports and things like that, and every country in the world is doing something here. And then you might ask yourself, is there any specific e-health technology? Is there any very thing you say, okay, this piece of equipment, that is very much e-health? And I say maybe. It depends on how you define technology. I mean, we have in this area a lot of interoperability standards, for instance, when we have different electronic patient records that should share data so that they both can technically interoperate with each other, but that they also understand what is the semantics in one solution and the others, then we need to have different types of standards so that we can combine those. And there are also things like security solutions, because security, integrity and stuff like that is very, very important in this area since we are dealing with sensitive data. But for me, I say that this is most standard technology that you apply in a specific context. And this is my message to the students also in the master's program, where we have a course in e-health in the biomedical engineering program. That this is the important thing to understand for you as technical people, is to understand that it's all about the context. Where do we apply this? And I see that any new ICT tool you bring out on the market can be used to support healthcare in one way or another. The important thing is how you use it, and also that you are aware of the limitations. Give you an example. A lot of people think that this should solve many of the problems we have with the elderly people and follow up on their diseases. They don't know how, most of them don't know how to use this. But then some people say, okay, that would be no problem, because when this generation, when I get old, which isn't that far away, you are able to handle that because you are part of the internet generation. But sometimes I check out also, don't follow what's happening. And I get old, I get problems with my senses, I will have problems seeing, hearing and whatever. So you always need to take this into account when you're dealing with patients or whatever. Who shall use this and what are the problems they have? So context for me means a lot of different things that you need to bring in before you start working with the technological tool case. For instance, what is it for? What type of care or medical problem is it that we should address, support or handle? Who are the intended users, as I said? What about legislation? There are a lot of different legislations to take into account when you're entering this area, both for what the devices or the applications shall do, but also what we are legally forced to do when it comes to integrity. There are ethical considerations on this. How much can we help people? Because we are dealing with sick people in many cases, and what is ethical to do and not. Also need to look into the technology that is available. For instance, if we are designing, which I will come back to, mobile solutions, what is the coverage? What is the availability of the networks we are intending to use? Will they help us in all situations? And if not, what shall we do when they doesn't work? Because again, we are dealing with people that are sick. Costs, of course, who shall provide the service, and in the end, of course, the benefits to the patient or whoever it is. And this is really the important thing to understand where you're entering this area. It's not so much about doing a lot of fancy technology, it's understanding where you shall use it. So, e-health has been around for a couple of years now and very much focus on it. And what is it that it becomes so interesting? What are the drivers for looking into e-health? And I would say that there are some 2 or 3 main drivers in this. And one of these are safety, because this is an old study that was done, I think it was in the beginning of 2000, something like that. It was done in the United States. And the book that came out was called To Err is Human. And what they found there was that at least 44,000 people or up to 98,000 people died each year in the healthcare sector due to mistakes. And that is pretty many. Afterwards, people have come to a conclusion that it might even be more. And these are preventable errors. And a lot of them are there because we don't have enough information, or we don't use the information we have in a good way, or we don't have supporting tools that helps us making the right decision. So this is a lot of people. They have been doing this in many other countries. Unfortunately, this is in Swedish, but a lot of you are Swedish, you can read here. But here is a shortcut on the essence of this slide. In Sweden, we say that it's approximately 3,000 people die each year in the healthcare sector due to mistakes and errors. They are called, again, preventable errors. And in traffic, we have below 300 a year. You all know about the zero vision for traffic. If you look into these figures, there were some 270 this year, I think, 2016. Half of them are in cars, the rest are in motorbikes, bikes and whatever, or pedestrians. And of this, then let's say 150 in cars. Some of them don't have their safety belt on. Some have the intention to kill themselves. And there are other reasons to say that we probably cannot do that much, at least when it comes to the cars. But we still have 3,000 dying in the healthcare sector. Maybe we should have some kind of zero vision for the healthcare sector so that people don't die by mistakes in the healthcare sector. And one of the things they have been looking at then is, can we use the information we have in a much more efficient way to make use of the information we have so that we can make it more safe to enter into the healthcare sector? Another thing that is really a challenge for all countries almost in the world is that we see increasing healthcare costs. And this is a study going all the way, I think it's to a very long time forward, 2050. But if you look at this, Sweden here for instance, we see that today we have approximately 10-11% healthcare costs. They expect that that will rise up to some 18% or something like that. And the reason for this is that we have a growing number of elderly. And we have an increasing number of elderly with multiple chronic diseases that needs to be taken care of. We live longer, we carry on more diseases as we grow older, and these need to be taken care of. And we don't have really the resources to cope up with this. It's a matter of money, it's a matter of people that can work in the healthcare sector. There's already now big deficit of people in the healthcare sector or in the home care sector. So something needs to be done on this. And people think then again that e-health might be the tool to use ICT in a more sufficient way, to reduce error, to find new ways to provide healthcare, and also promote people staying healthy. For instance, by having apps that assist you in living a good life, or we can have apps that promote more psychiatric problems and stuff like that. So this is another thing. And of course, since this is so important and every country almost sits in the same problem, a lot of things are being done all around the world. And these are just some examples. But here in Sweden, for instance, we launched already in 2005, I think it was, the first strategy for what is e-health. It was updated in 2009 and also in 2010. And now, 2016, this new government issued this plan, the vision for e-health up to 2025. And they have been questioned because they say here that we should be the best land in the world, country in the world, when it comes to providing e-health. But the important thing is what it says here, to make it easier for people to achieve good and equal health and welfare. So we shall use ICT to really support this goal, that no matter where you are, who you are, how old you are, what sex, etc., we should use ICT to provide health in a better way, to make it easier to get in contact with the healthcare sector, book your appointment and whatever. Follow up on what we are doing. So that about e-health in general. Any questions so far? Otherwise I have a little bit of coffee. And then we go into pre-hospital care. My favorite subject. No. What is pre-hospital care? Well, pre-hospital care is something happens before you enter into a hospital. That's very obvious. And we very much look into what we call care chain or care processes. And you could say that it's something that starts when an incident happens somewhere. Someone calls for help. It could be that you are in your home, or it could be an accident out on the road. And then it takes you all the way through call taking, for instance, at 112 or the PSAP, the dispatching procedure if they shall send out an ambulance or anything like that. You provide care on site, maybe in a transport, and at the end you deliver those that are involved at the right hospital and at the right department. So that is the complete care chain. And it's very often mobile, takes place in ambulances, but it could also be helicopters or airplane or boats. And as I said, outside hospitals. It covers anything from a small incident to what I call the large incident or the catastrophe. Because a small incident could be if one of us gets sick and need an ambulance. But we can also have a big accident happening down in the city, or a train crash or whatever. Then it's still the same people that should carry out the work on the field. And of course, this needs cooperation between a lot of different stakeholders, and a lot of information should be communicated between all those involved, including anything like bringing out information from the hospital. If I'm in a situation where I've got a stroke, it's very good to see if there is any information already available, if I've had those problems before, am I allergic to something or whatever. And of course it ends up in that you should have good and interacting ICT solutions. And this is a way to illustrate what this is. There might be some kind of traffic accident, someone calls in to the 112. Someone might even send in photographs. They are looking into that now, if we can use images in trying to understand what's happening. And there could be other ways in as well. What is coming, and I'll try to mention this a little bit later, is that we will have e-codes coming up, that the car automatically sends a notification that something has happened. So in fact, the care chain starts by an automatic alert from a car. Then there will be a lot of different things, dispatches like ambulances or whatever, and we end up in at the accident site, and all these need to communicate with each other. But apart from that, we can also call into the 112, or even through what is called 1177. I don't know if you know about that, but that is where you can get advice, for instance. They are also part of this pre-hospital chain. And once you are on scene, then you have a lot of different ways to handle this. But you can also be involved that you should only go to the primary care, because what can happen is that the ambulance service decides that you should stay at home. This is nothing that you should go to a hospital. They could treat you at home or send you to the primary care the next day. So again, there's a lot of information that should be transferred around. And I will give you some examples what this could mean for two different types of diseases, which have a lot in common, but where time is the crucial things. And one of them is myocardial infarction. And that is that one way or another, you get a clot somewhere in the coronary vessels, stopping the blood from flowing, and then you get ischemia, and strange things start to happen with your heart. And the important thing here is time, because as soon as this process starts, heart muscle starts to die. And the longer time it goes, the more heart muscle dies, and the worse is it for the patient. And here you can see, for instance, these are old data, but a very famous study said that if you can start what is called the thrombolytic treatment, that is something that dissolves this clot in the vessel, within 1 hour, you reduce the mortality with up to 50%. And as time goes on, of course, the effect becomes less and less. Just to give you a figure, I think in Sweden there are some 25,000 cases a year. And some 25% dies within 30 days. Nowadays, some 10-15 years ago, we were up to 40-50% that died within 30 days. And this is partly due to what I will describe right now. And you can say that there are two major treatments if you have an acute myocardial infarction. One is to do what I mentioned, thrombolytic treatment, that is you give a drug that dissolves the clot. The other way is to do a mechanical so-called PCI, that is you go in with a catheter into the vessels and expand the vessels so that the clot goes away, and then you dissolve it. And it has been found now that PCI is the most efficient thing to do if you can do it quickly enough. But that can only be done at certain hospitals where they have these facilities, so it cannot be done everywhere. And this is really what it's all about. And this is where we started working with the MobiMed system a long time ago, some 30 years ago, when we started in this, was that time is muscle. And if something happens here, as I said, there is a decrease in living heart tissue until you do something to stop it. And if you look at the delays in this process, you can see that first of all we have a delay, for instance, at home. We don't realize that we are sick, we have pain, but we don't do anything. Then we decide to go to the hospital. If we are lucky, we call for an ambulance. Otherwise, we try to go there some other way. So there is a transport delay. And we also have something called the hospital delay. In the old days, it could take between 30 and more than 180 minutes when you went to the hospital until you got proper treatment. And that's, of course, very dangerous if you remember the figure before. So what we wanted to do was to reduce the delays, both to pre-hospital thrombolysis and to PCI. So the first thing we did was try to move the diagnosis. If we can send an ECG, which is the main thing to do here, from the ambulance, a diagnostic ECG, to someone that could look at it, we could see immediately, okay, this is a myocardial infarction that shall have this type of treatment. So then we could prepare for the patient in the right way so that we again could reduce the delays. The next step was to move the treatment, because if we were sure that this was a myocardial infarction and we have a doctor at the hospital saying, okay, you can start up this treatment, they could give the drug already in the ambulance. And then we need to have a 12-lead ECG and something called ST elevation analysis, because the ST elevations tells you if there is an ischemia, a lack of oxygen in the heart muscle. So that was really what we did with the MobiMed system. And this is what the 12-lead ECG looked like. I don't know, you haven't had that course yet, but you look at the heart, you can say, in 12 different directions. And depending where you have changes, you can see where the myocardial infarction is, how big it is, and things like that. And that is the one they are making the diagnosis on, apart from other observations. But this is essential. And we need to send this. And this was the challenge when we started developing this MobiMed system, because we had then a basic idea of a system for collecting and analyzing this type of information. And we started working with a system called MobiText. But why did we do that? We know that that would cover the whole of Sweden. And every blue light vehicle would have it. So we started using that. But the problem was, it was very low bandwidth, 1200 baud. That isn't much. So we needed to find ways how we could handle this very narrow bandwidth in order to send essential information. And this is really what the MobiMed system was about. It started to work when we were in the ambulance. We could use some kind of tablet, for instance, bring it up to the patient, send ECGs, have an electronic patient record and things like that, and always communicate with one or more hospitals and get information from the hospital. We can continue during the transport, have feedback from doctors, and then when we got and delivered the patient, we could bring the information into the electronic patient records and follow-ups. Today the system is still around. I left this company 4 years ago now, but it's around. They are using more modern stuff now, and there are some 1,500 or something ambulances out there somewhere using those. And the largest installation is in UK, so you can see it in the website if you like to. But it's still around and being used for a lot of different types of things. And when we are running this type of systems, as you understand, there are a lot of different communication systems that we use. I would say that there isn't any that we haven't tested. We started with MobiText, then it was GPRS, 4G, Tetra, Oracle, or whatever. So we use what's around, satellite, and things like that. And in background, and here we have a lot of other stuff with connections to other systems, storing of ECGs and things like that. I think we have to skip those, and also why we are using these. So, some more about the communication here. We had limited bandwidth. We had 1200 bits to start with. It was a bit unreliable. I usually say that the only thing you can be sure of when you use mobile communication is that it goes down. And when it does, you need to have a strategy on what to do. So therefore, we need to handle that in one way or another. We use, for instance, local buffering. We always had all data stored locally. Automatic reconnection when we got the communication there again. And we had to do some smartness in the ambulance so that we only sent over what was relevant information for handling this situation. And this is just to show you what happens when we get more baud rate. From the beginning, we only sent what was 12 lead average reports and then one channel of a rhythm curve. But as it became more and more bandwidth available, we could, of course, put more information into what we sent. So this is a way to deal with the context, that when we have better communication and things like that, we can do more stuff. We also used Bluetooth. About year 2000, we introduced the first communication link between a measuring unit and some kind of PC platform. And Bluetooth is very interesting to use here because it's more robust than, for instance, Wi-Fi. They use the same frequency band, but Bluetooth is adapting and only use those channels where there isn't any disturbances from the Wi-Fi net. So that is very good to use for this type of solutions. We also use that in telemetry in hospitals for this coronet system I was mentioning. I'm still very much involved in the pre-hospital area, and we have an open arena at Lindholmen which I'm running, where we're trying to improve how we utilize ICT in the healthcare sector or in the pre-hospital sector. We skip those because I need to come to some at the end here. I see that time is rushing. Another thing we are now looking into, which I said is very similar to myocardial infarction, is stroke. And you have the figures down here. 25,000 cases a year in Sweden, mortality approximately 20%. 30% of the patient needs assistance of another person, life out. And the rest 50% might have more or less neurological disorders. So it costs in Sweden about 19 billion Swedish kronor a year. So there's a lot to do with this. And we have the same type of problem here. We need to early identify which type of patient do we have, which treatment is most appropriate, and make sure that we can bring this patient to the right place. And here are also two strategies. One is called thrombolytic treatment again. It's this drug dissolved in the cloth. And the other one is called thrombectomy. And that is again going in with a catheter up into the head and bringing out what is stopping the blood from flowing. And that can only be done, for instance, in the whole region of Västra Götaland. This can only be done at Sahlgrenska Hospital. So if we have a patient way out in Västra Götaland, up in Dalsland or somewhere, we need to make a decision there. Where shall we bring this patient? What type of problem does he have? Is he suitable for this treatment, or could we do something else? And in order to support that, we need to have communication between doctors, the people in the ambulance, and others that support these decisions. So this is again brain cells. And I just want to show you a couple of slides here at the end. Yeah, I can mention this. What we have done now is that we have worked with the ICT support here to find ways to be able to communicate and exchange data in this process. And what we are now going into is to start to use video in the ambulance, so that we can have a background from a neurologist, that is a stroke expert, to help making those decisions on where to take the patient. And here is another example where they are doing this. This is in Berlin. They have what they call STEMO ambulances. They are equipped with CT scans and stuff like that to do all this diagnosis out on the field. But one of these costs about 20 million Swedish kronor, so they are not that relevant to have, in fact, here. And just to give you an idea on what they are using here, what we also will use is that we use what is called 3G or 4G bonding routers for the mobile communication. So we put in a couple of SIM cards, 4, 5, 6 or something like that, different operators, making sure that we always have someone that has a connection. And the good thing with this bonding is that you can also add the capacity from each vendor. Not that you will get 5 times if you have 5 SIM cards, but 4 times maybe, and in the end you put them together again so that you get the correct image. So here we will send live streaming video. And this is the one where you have to skip. This is what we use, and this is the one which is the end, is that when it comes to e-health and communication in this pre-hospital area, I would say that the application context is always the fundamental importance, and this puts focus on the bandwidth, coverage, redundancy, shall we have alternative communication ways, the availability of them, how reliable are they, what costs are we have to deal with, and the security, and of course always the user integrity. And as I said, when it comes to mobile communication, the only thing you can be sure of is that it will go down. And these things always need to be taken into consideration. I always have too much to say, too little time. Thank you. I can take any questions afterwards if you like to.
All right, thank you. Do you have any questions for Bengt? All right, if not, then thank you for your presentation.
Thank you. I have to show you this one. You can see here, this is from 1924. So I usually say there is nothing new under the sun. This is telemedicine in 1924. Here is the antenna, the aerial. Here is some kind of television set, a loudspeaker, and there is a doctor in the other end telling this guy what he should do. So it's really amazing.
It's like being doctor.
Yeah.